Good morning. I would like to thank the Asia Pacific Society, the co-authors and moderators for giving me the opportunity to present our study. We have no disclosures. So total hip arthroplasty improves function and quality of life. It is the fourth most expensive hospital discharge procedure, at least in the United States, that costs at least $1,798 to $2,300 per night. In 2018, the Center for Medicare and Medicaid approves total knee arthroplasty as an outpatient procedure. However, total hip is not approved yet, but it is to follow. The implementation of pathways, including preoperative education, preoperative pain control, and appropriate discharge planning, have helped decrease length of stays. However, there's controversy remaining with the safety of accelerated discharge protocols, and especially this is true in teaching institutions. The purpose of this study was to determine if early discharge on post-operative day 2 was associated with an increase in emergency ER visits, hospital readmission rates, and post-operative complication within the 90-day global period. This was a retrospective study of all patients who underwent total hip arthroplasty between 2015 and 2017 in our single institution in New Jersey. We have about 600 beds in the hospital. We identified 260 patients, 146 women, 114 men. Mean age was 66 years old. In 2015, we kind of started a new accelerated discharge protocol for our patients. Our mean length of stay was about 5 to 7 days prior to that for all total hip patients. We attempted to reduce that with emphasis on multimodal pain control, multidisciplinary team protocol, as well as patient education. So we were able to have two groups, everyone who left at day 2 with all our efforts, and the ones that were not able to leave regardless of what we did. And within 90 days, we looked at emergency visits, readmission, and if there was any complications. Most patients received spinal anesthesia under conscious sedations. There were a few instances that the anesthesiologist didn't feel comfortable, so we used general anesthesia. All patients received 2 grams of IV ANSEF 30 minutes prior and 2 doses within the 24-hour period. We used a multimodal pain protocol with intraoperative capsule injection of morphine, toradol, provocaine, and epinephrine, post-operative adductor canal, pre- or post-operative canal block, as well as post-operative pain medication protocol with emphasis on reducing the narcotics. Our DVT prophylaxis was 325 aspirin for everybody. In some patients, they received Lovenox as well. We also used mechanical prophylaxis for all patients. So in our results, we're looking at patients who were able to leave at day 2 versus day 3. Most patients were still staying more than 3 days, 3 or more. However, we were able to at least 30-40% discharge them on day 2. Male were easier to be discharged on day 2 compared to females. The day 2 appears to be slightly younger. This was significant, however, clinically might not be significant. Our length of stay for the 2 days was less than 2, and for greater than 3 was 3.5 days, which was still better than our 5 to 7 days. However, surprisingly, we had less readmissions with the early discharge and less ER visits with the early discharge compared to higher length of stay. When we looked at the complications, there was also higher complications with longer length of stay. Overall complication was lower in early discharge. Periprosthetic fractures similar. Dislocation was lower. Infection was lower. Anything that was significantly important for total hip was actually lower with early discharge. The conclusion is that even in teaching institutions with appropriate planning and patient education, earlier discharge may be safe. We didn't see any significant differences between complication and readmission between the two groups, and a majority were able to be discharged and were younger. However, there are reports of same-day discharge. So this paper compared to those paper might actually have an older message. However, in teaching institutions, it's much, much difficult to discharge patients earlier. You're fighting with all groups, you're fighting with different teams, you're fighting with social workers. So for us, discharging them at least 50% reduction was significant.
Thank you. So any questions from the floor?
So I think two questions. One is, were all discharges defined as discharge home or to some other care facility?
Discharge home.
And with your data analysis there, it's probably safer to say that there weren't less complications in the early discharges, just that those who had complications stayed longer. Would that be fair?
Potentially. But we were most interested about post-operative complications. If they got DVT, if they got pulmonary embolisms, if they got periplastic infection after they were discharged. Intraoperatively, there were few instances of patients who stayed longer because they had intraoperative complications.
Yep.
But for the most part, these were like within 90-day global period. Okay.
Thank you.
Thank you.